Our first question is, what is your professional experience in the field and how long have you been working within it?
So I am a breast imaging and interventional specialist here. I'm currently an Eastern radiologist. I've been working here for a little over a year and a half. I was board certified in radiology in 2013 and did a fellowship in breast imaging for a year. So however long that might be. Technically, I've been out of training for a year and a half, but.
What do you think the main reason behind the racial disparities in breast cancer is?
Well, I mean, I think there are a couple of factors. So there are obviously your genetic or familial, and then there are going to be your socioeconomic, which then plays into two things: access to healthcare but also environment, right? Mm-hmm. So we know that our risk factors to the development of breast cancer are the modifiable and then the non-modifiable. Your non-modifiable being any family history, if you have a genetic mutation, and then your modifiable being any hormone use, oral contraceptives, or hormone replacement therapy, and then obesity, alcohol consumption, things like that. So that's going to play in. It's linked to socioeconomic, but then it also can be sort of a cultural or so it kind of has those, and then access to healthcare. So we know that early prevention or early detection rather helps to have more treatable, more survivable disease, and there are various communities who have limited access to healthcare. So those are going to be your main ones. But I also know, having worked in DC when I was at GW for fellowship, our indigent population of African Americans presented at more aggressive stages, but so did our affluent African American population. So then you have to suspect that there's a genetic component as well, which just hasn't been as well delineated. The BRCA1 and 2 genes are the better known, but we know that there have to be other ones. And those are more prevalent in the Ashkenazi Jewish community and some within the African American community, but there have to be others that we just don't know about. So.
You were saying, you mentioned something about hormones and oral contraceptives that affects it?
Yes, so breast cancer, for the most part, is a hormonally sensitive and influenced cancer. So there are actually receptors on many breast cancers that are sensitive to estrogen, progesterone, and then one other component. And so you're increasing your risk anytime you are taking those. So in fact, there are some women who have had early onset of menses, late onset of menopause. They took oral contraceptives for years. They're at increased risk for the development of breast cancer without having any family history.
Okay.
So there are models, the tyroacoustic model and the Gale model, which can show you what your level of risk is and what some of the components are. So.
Do you think that new technology changed the survival rates in the treatments and just how quick it can be cured? Well, not cured, but just through remission. Yeah.
So we know that, again, early detection, right, can help breast cancer be more survivable just based on the fact that if it presents at a lower stage and a smaller tumor size, it's a more manageable disease process. And it's not just linked to mortality, it's also linked to morbidity, right? So you can have really significant impact on morbidity if you catch something earlier. So in terms of technologies, yes, so even as recent as 10 years ago, facilities were using screen film technology. Now we're using digital technology, and we've even moved past just your standard 2D mammogram and are doing 3D mammography, breast tomosynthesis. So we even have in addition to increased cancer detection, we now actually have decreased false positives. So yes, I certainly think that in terms of cancer detection, that we have impacted the survivability. And then of course, and I am not an expert on treatment, that would certainly be an oncologist or a surgeon, but obviously the breast cancer treatments have impacted the ability to survive the disease, to go into remission, and to have the 5-year survival rates, morbidity, and mortality. So
Do you think that health insurance is doing enough to to help African Americans move toward breast cancer, like just prevention, just going to mammograms, and just doing all that?
I can say from the various communities that I've lived in, I'm not sure per se what insurance providers can impact. I mean, your well woman exam is included in any insurance program. No woman has to pay out of pocket for a screening mammogram if she has insurance. So, I mean, to answer that question, I would say yes. They're covering it. Now, whether it's being utilized or not is, not something that they can necessarily control. Although I have heard that there are some insurance companies that are incentivizing mammograms. So they're giving patients money or some form of, rebate or reimbursement for obtaining screening exams such as mammography, which I think is a great idea, because at the end you're saving money, right? If you go and get your regular screening exams and you're catching things early and you're not preventing at these advanced stages. So it's an interesting concept. In terms of access to healthcare overall, in the communities that I've lived in, there are always ways to access screening mammography. So here we have the Leo Jenkins Cancer Center that has the Susan G. Komen grants, and then we also have
them.
Yeah, so and then we also have the Pitt County Health Department that has a free screening program, and we typically image about 30 women per clinic, and so that's a great way. When I was in DC, there were plenty of charities that were geared toward that. GW specifically had like a mobile mammography unit that would go around to community health clinics.
So that is a thing.
Centers.
We were wondering if that was a thing. Like if is it like how the where they take blood? Is it kind of like that?
It basically, yes, yeah. So
Okay.
it quite frankly was a mammal van.
Okay, we
Is
weren't
what-
sure if that was too far fetched. We were thinking of ideas.
No, I mean, it's certainly,
Yeah,
does
it's done,
present
yeah.
some limitations. I would suspect that there would be limitations with maybe, larger individuals. Obviously things like handicap, accessibility. Like
Yeah.
I couldn't speak to that at length. I never actually entered.
Okay.
No, I did enter the mammo van. So, I mean, it was like getting up into a trailer. So I would think that there would be limitations in terms of
What can be done there?
right.
Okay.
But I think for your average female who has limited access to healthcare or no insurance, it would be. But for some women, I mean, we had working women who also used the mammo van. They had insurance and they, were DC executives and they just couldn't get to a screening facility, or they, in their own minds, it was just more inconvenient to do that.
Do you know what the cost of screenings if you don't have health insurance by any chance?
I don't, but our manager could certainly speak more in depth regarding that. I'm sure she'd be happy to give you some numbers. Now, callbacks from screening mammographies are not necessarily completely covered. And in fact, I don't think they're completely covered by insurance companies, which is an unfortunate.
Do you think that discourages women from even getting the screening because they might think like, if I get screening and if something happens, I can't even afford to get it fixed?
That could certainly, I can't speak. I don't know, have any numbers or data on that, but I would think, as someone who has healthcare costs, and I think that would be an unfortunate but reasonable thought process that people might think that sure, this is paid for, but I can't pay for X, so what's the point? And again, I think it would be helpful for women to know that there are resources out there, so that might not be how they feel.
And do you believe that maybe the cultural beliefs of African Americans might be affecting the screening, or if you know that there's some do you know any barriers that could affect?
I mean, I do know that there's going to be a certain fear of healthcare professionals. There's going to be a certain fear of treatment. Can I speak specifically to the African American community? No, but I do know that different cultures have different beliefs about obtaining healthcare. For example, the Jehovah's Witness population, for example, they might not necessarily seek it out based on some of their beliefs. So I think that those can play in. I mean, we certainly see women who present at advanced stages, and you have to think there was a component of denial, you know, for whatever reason.
Do you think that like a good source of education or like a program or something would help change that?
I do, and you know, I've personally been involved in some, and so has Dr. Griffin, our medical director. You know, and in fact, there was a large consortium that I attended last year that was focused on African American breast cancer disparities, and it was teaching women, you know, how to do their self-breast exam, teaching women that if they had early access to care, they, you know, have increased survivability. Teaching them, I mean, I was telling them that, you know, not every palpable lump is going to be cancer. You know, so don't put yourself into that mindset already, but then at the same time, don't come in because you think like, oh, it's just a cyst.
Yeah.
My sister had cysts, so I have cysts.
Yeah.
You know, there's a lot of, not just in that community, I mean, in many communities, like, you know, women forget that breast cancer is, you know, really common and increasingly common as we age, so they'll think like, oh, my grandmother had it, I feel something, I must definitely have it, you know? Not taking into account that 1 in 8 women develop breast cancer, and the top 2 risk factors for developing breast cancer are aging and female. So your grandmother developing breast cancer at 85 probably was just sporadic background population risk, you know, so just things like that we see every day.
Did you notice any like major myths that came up with breast cancer, like when you were doing educational events? Like just a lot of comments that a lot of women thought too. Like I noticed that someone thought it was contagious, like the cold, when I went to some.
Yeah, I've not
stuff like
necessarily had that exact. I mean, I think, you know, women, you know, will think like I do everything right, I exercise, I eat healthy, I don't smoke, why do I have cancer? And I think it's that's definitely something that, you know, women,
They just think if they live a healthy
right,
lifestyle,
they think
it should
like,
be
you know,
cleared.
which is obviously related to cardiovascular health or,
Yeah.
you know, other aspects of life, but cancer can form outside of a healthy lifestyle. And that's not to say that we don't promote it, but there's a reason that we have these screening exams. So I see women who think like, well, I live a healthy life, so there's no need for me to do this. Other common ones, I mean, things like, you know, thinking that caffeine causes cancer, or again, I find family history to be
The biggest one.
a big one where well, they'll think either way. They'll think, well, no one else in my family has ever had cancer. You know, we don't have cancer in our family. And I'm like, oh, and that's great, you know, which means you don't have a strong family predilection, but that doesn't mean that you shouldn't get your screening exam.
Do you think that there's anything women can do to lower their risk? Because you did say that
Your modifiable risk factors, obviously. So yeah, so you know, avoidance of exogenous hormones. So again, the hormonal oral contraceptives, or hormonal contraceptives in general, including like the hormonal IUDs or hormone replacement therapy in postmenopausal females, alcohol consumption, and obesity. I mean, we know that fat cells produce estrogen and can increase the risk for the development of breast cancer. And there's a couple others I'm forgetting right now. I mean, you know, a technically modifiable one is having your first child after 30, so it actually increases your cancer risk, but that's, you know, for women is not modifiable based on personal factors, but yeah.
a new thing that
There's one more person here for the interview. Is that right?
Right. Yeah, she was lost.
Is this all?
Yes.
Okay.
a new thing that a lot of people are saying is that they're not encouraging self-breast exams anymore. I don't know if you've heard that. Do you think that is a good way to do, like, not do it and just stick to the annual screening, or?
So we know that with both provider and patient breast exams, there are false positives. So there are a lot of workups that lead to, you know, it really leads to a lot of unnecessary workups. It's hard for me to really say, you know, to discourage someone from doing that. I think that if women were to be getting their annual screening mammography regularly, then, you know, it would lessen that need. I still think it's important to be aware of your body, but I do encourage women to sort of monitor things, right? You don't need to come in the second that you feel something. Maybe you should give it a week or two. Maybe you should. My other thing is that in women who are in their 20s and 30s who wouldn't be getting screening mammograms because it's not, you know, been proven to be helpful. The cost benefit in someone in their 20s or 30s is quite low. We can grab a chair from that room. Is that door closed? Oh, that's the bathroom. Okay, let me. If you'll just, Erin, can we just grab her a chair? Dr. Then.
You were saying women in their 20s and 30s.
Oh, right.
Like,
So then I think that physical exam would be important for them because
Okay.
we do have women who present with palpables at that age that do turn out to be cancer. Now the likelihood is low in a 20-year-old, but you know, I mean, we just had a 34-year-old with a palpable that was cancer, so
really?
it's not uncommon.
Okay.
What age do you believe that a woman should start getting a mammogram? And then at what age do you think is the most common that they actually start coming in?
I mean, the Society of Breast Imaging, the American College of Radiology, the American College of Breast Surgeons, and the American College of Surgery all support starting annual screening mammography at the age of 40. So we don't agree with the American Cancer Society or the USPSTF breast cancer screening guidelines. So there is plenty of data from the National Cancer Institute and other studies that have shown that the 1 in 4 to 1 in 5, it's sort of variable, women who are newly diagnosed with breast cancer are in their 40s, like the 40 to 49 age range, that they have a significant decreased mortality, reduction in mortality from annual screening mammography and early detection. So I can't tell you an average baseline screening mammogram. I mean, even in well-educated, insured, women, I see them coming in at 42 or, getting it at 42 and then not again until 40. It is hard to keep up with these things. I'm not saying that that's not true, but I think both patients and physicians just need to be more vigilant.
Have you noticed any trends just on breast cancer rates? Do you think it's increased or decreased? I mean, well, you've only been working here, maybe in that year, have you seen any?
I mean, I think the things that I notice, or I'm alarmed about the most, I'm interested to see where it takes us, is the development of breast cancer in women in their 20s and 30s. I do not think they need to be screened, but I think that a lot of this can be due, could be due to our environmental factors. I mean, we have women now for decades who have been taking oral contraceptives many times since, their mid-teens. And we know that we have hormones in our food. We have all these, we have increased consumption of soy. We have, so we have all these things that haven't necessarily had a direct link to the development of breast cancer, but you have women who are sporadically developing breast cancer without known family history, without other members having developed it. So one has to assume that, or not, I mean, you can't assume, right, it's science, but one has to question whether there could be an environmental change that's going to shift the age for the development of breast cancer. I mean, I think already the average age from the NCI for the early 2000s was 65, and it's already, I think, now shifted down to 62 or 61, which doesn't seem significant, but I mean,
Over time.
kind of is. Right. So if that were to shift,
Continuously shift.
Right.
That's really interesting.
So.
Do you
Well,
believe?
concerning.
It is concerning. Do you believe that women are educated, just as a whole? Do you think that they're educated enough on breast cancer and their prevention just to come to like a mammogram? Do you think that they're educated enough, or should we put more into?
I do believe in patient education and empowerment, and that's a lot of what I try to do. And no, I think even women who come for their yearly exam don't necessarily know what we're looking at, what we're looking for, why we're doing what we're doing, why we call them back. I mean, women, so from an annual screening mammogram, and this would be your 2D. I don't, have the exact data for 3D, but for 2D screening mammograms, about 10% of women on average are called back for a return visit. Now, so say
How
you
much
have
was that?
10%.
10%?
So 10 to 12%. So if you
Okay.
have a screening population of 100 women, and 10 to 12% of those are called back for a return visit, I think the number is like 20 of those will then be recommended for a biopsy, and only 5 of those will have cancer. So, but the 1,000 women who come for their screening mammogram don't know that statistic. But certainly the 10% that get called back don't know that statistic. That the 20 that get recommended for that biopsy. So I really try to empower women with these numbers. Not to say, again, like, don't worry about it, don't be flippant, but I just want them to be empowered with that knowledge that, you just have to take it one step at a time. When I do recommend a biopsy for a woman and she's, hysterical, I try to tell her 80% of what we biopsy is benign. Not because we're bad at what we do, but because based on, epidemiology, based on sort of background population risk, we have to have a positive and negative predictive value, right? That falls within a certain range. We can't have a 100% positive biopsy rate because then we're definitely going to be missing things.
Yeah.
It's just sort of the sensitivity and specificity of any exam that we're
And
doing.
if they do have to come back for the, like, if they were called back, that might not be covered in their insurance.
I don't know. Again, our office manager would definitely be more well versed in actual economics or cost. I do know that screening is covered 100% without question for any insured female. For any insured female over the age of 40, and some insurance companies will cover a baseline either at the age of 35 or 37. Now, if you try to get a screening mammogram at the age of 30, your insurance company is not going to pay for it. You would have to get a diagnostic mammogram based on the fact that you're feeling something or whatever before the age of 40.
I've heard that if you have history of breast cancer, you can get it 10 years earlier.
So if you have, so the breast cancer statistics are that 1 in 8 women will develop breast cancer, right? So that's 12% if you do the math. And that is background low risk, even though it seems high, but it's low risk. So high risk is defined as greater than 20% lifetime risk for the development of breast cancer. So women who fall into that are women who have a first degree relative who had premenopausal breast cancer and a known genetic mutation, a history of chest radiation, and of course a personal history of breast cancer. So again, I kind of referenced the grandmother at 85. If your grandmother developed breast cancer at 85, you can start your annual screening mammogram at 40 because 85 minus 10 anyway, and she was postmenopausal. That's all in your background risk. If your mom or grandmother developed it at 50, you're still going to start at 40. But then if you start creeping below 50, that's when we start saying 10 years before. By the American College of Radiology standards, we will not do a mammogram on a baseline background risk female before the age of 30. So if any of you were to say, I have a lump and you're below the age of 30 and you have no, strong family history, we would only do an ultrasound. But if you had strong family history and needed to start high-risk screening, we could start doing mammograms at the age of 25. But that's only if you have a greater than 20%.
And you need proof of that? Or do you just need to just tell them?
I mean, you would tell your healthcare provider who would make that referral because, you probably have to,
Have some history.
end up, filing a claim with your insurance company. But
why is it that, like, the guidelines for the age is so strict like that? Why can't you
cost
start
benefit, right? So we know that statistically, women in their 20s and 30s have extremely dense breast tissue, or at least heterogeneously dense breast tissue, which limits the sensitivity of mammography. And so we're probably not going to be able to see much of what is being, felt anyway. And you're just getting, unnecessary radiation versus ultrasound is non-ionizing radiation and can generally clearly depict the problem. Now, have every one of us in this office broken that rule every now and then because, what we saw in ultrasound just didn't look quite right. Yes, every now and then. But American College of Radiology standards dictate those ages. So, and have we then broken those rules and found cancer? Yes. Have we broken those rules and it been negative? Yes. So
those are all our questions. Do you guys have anything else to ask?
I don't think so. Do you have anything to add?
Gosh, not really. I mean, I do think, and I'm sure you've seen the graphs that, and if I can access that, I have like a couple of presentations. But, I'm sure you've seen like the development of breast cancer versus the mortality graphs. I mean, I would have to have shown you guys those in your classes, but so like the incidence rates by race and ethnicity. So again, black versus white versus all versus whatever. It's not that they have a predilection for the development of it. Where's my death rates? Yeah, but then you see death. You see mortality, and your African American is significantly above your all races or your white.
Is there any way that we could have access to this slideshow?
I can give you some of the slides. I can certainly give you some of the slides.
Some of the graphs would be wonderful.
Yeah.
I'm trying to think. I used to have the reference where I got them. So I will tell you that because those are also going to be old, so I would actually recommend that, if you're trying to put something together that you use. So the NCI, the National Cancer Institute, can tell you cancer statistics based on pretty much anything you're going to want to know, right? So they're going to have all sorts of really useful graphs, stuff like that, like, again, the ages, race and ethnicity, who dies from this. So I think,
This would be our best bet.
I find NCI to be a really useful resource. So it's not, this is 99 to 2011, like there's going to be an update. Something that's more, I just think, I should probably be changing mine too, but, so, yeah, that's about it. I really think it's patient education and access.
Okay. And you said that we can find out more about insurance and everything by talking to the officer.
Yeah, I can go grab Missy, and then if you guys need my contact information, if you have any other questions, I don't know that, again, I would be,
Yeah, you can just
much.
don't mind my scribbled notes there.